Okay, this is Mrs. Dagan podcasting for Nursing 151 on rheumatoid arthritis and lupus. And again, the concept that we're going to be focusing on is immunity. Rheumatoid arthritis considered a connective tissue immune-mediated disease. It's the most common inflammatory arthritic disorder. So remember we talked about that rheumatoid arthritis is a problem with the immune system. So it's chronic and progressive. The typical course of rheumatoid arthritis has exacerbations and remissions. The cause for rheumatoid arthritis is unknown. The thought is that the immune system loses its ability to tell the difference between foreign invaders and the body's normal cells. Those at risk for developing rheumatoid arthritis include those who have had infectious diseases, such as the Epstein-Barr virus, and genetics play a role. They also suspect that female reproductive hormones play a part because it affects more women than men. Rheumatoid arthritis typically occurs after age 40, but it can also occur in adults anywhere between 20 years and up. But the most typical would be after age 40. There's a theory that infectious organisms play a role, such as the Epstein-Barr virus, which causes mono. So certain viruses might put someone more at risk to getting rheumatoid arthritis. And physical and emotional stresses have been linked to the exacerbations of the disorder and may be contributing factors in its development. So again, we don't totally know the cause of rheumatoid arthritis, but have some theories on what contributes to it. The pathophysiology of rheumatoid arthritis. Remember we talked about the wear and tear damage of osteoarthritis. Well, the pathophys of rheumatoid arthritis affects the lining of the joints, the synovial tissue. So rheumatoid factor antibodies develop, which is an antibody that's not normally present. And these rheumatoid factor antibodies develop in the synovium to fight IgG. Remember that IgG works to protect the body from infection. And IgG are normal antibodies that are in the blood. So again, we have this rheumatoid factor antibodies, and then they start fighting the normal antibodies that you have, and they link on to the IgG complexes. This combination of the rheumatoid factor antibodies and the IgG complexes looks like a foreign substance that needs to be destroyed. So inflammation results. And again, inflammation results because of the activation of the complement system. So complement proteins, which cause blood vessels to become dilated, contributes to the red, the warmth, the swelling, the pain, and loss of function that goes with this inflammatory response. Enzymes break down collagen, and it causes edema. And then we have the pannus formation, which results from the formation of vascular granular tissue. I'm sorry, I said that, pannus formation. So again, what I wanted you to really know about rheumatoid arthritis is that it is an immune inflammatory response. And because these rheumatoid factor antibodies and the IgG complex form a complex together, it's looked at by the immune system as a foreign substance that needs to be destroyed. And that's how we get this inflammation, swelling, pain, and loss of function. The pannus formation, there's a picture of it. The pannus formation looks like vascular granulation tissue. So you can see in the picture there the inflamed synovial membrane and then the pannus formation. So this pannus has a destructive effect on the adjacent cartilage and bone. What are we going to see with rheumatoid arthritis? Well, a cardinal early sign of rheumatoid arthritis is early morning stiffness. The onset is usually acute. It doesn't have to be, but it usually is acute. The symptoms include joint pain, swelling, warmth, edema, erythema, which is redness, and lack of function. So all classic signs include joint pain, swelling, warmth, erythema, and lack of function. Rheumatoid arthritis usually begins with small joints, such as the hands, wrists, and feet. And the symptoms of rheumatoid arthritis are usually bilateral and symmetric. The disease progresses, deformities of the hand and feet are common. And also as the disease progresses, knees, shoulders, hips, elbows, ankles, cervical spine can all be affected. There's also something called rheumatoid nodules, which usually occurs with more advanced rheumatoid arthritis. And I can show you a picture of this in class. It appears on bony prominences. And picture I have is on the elbows. But they're non-tender and they're movable in the subcutaneous tissue. So rheumatoid nodules you may see with more advanced RA. And then the key differentiation with rheumatoid arthritis is that it has systemic involvement. So these patients that are developing rheumatoid arthritis, when it becomes systemic, might exhibit things like fever, weight loss, fatigue, anemia, Raynaud's symptoms, which is like they can have coldness in their hands, lymph node enlargement, pericarditis, neuropathy, dry eyes, and they can have shortness of breath with inflammation around the lungs. So what are we going to see when we examine these patients? Well, we can do a palpation of the joints. And again, rheumatoid arthritis usually starts in the hands. So we can look at the interphalangeal joints and the knuckles and see that we have spongy or boggy joints. Tenderness of the joints, swelling, and they could have actual deformity. There's two deformities that are associated with rheumatoid arthritis. One's called the swan neck, another one's called the boutonniere. The swan neck is the hyperextension of the proximal interphalangeal joints. I can show you a picture of that in class. And the boutonniere is the flexion of the proximal interphalangeal joints. Again, we might see these rheumatoid nodules upon examination. They're small, non-tender, and movable. Again, the symptoms are usually bilateral and symmetric. Cardinal sign with the patient's history, talking to the patient, is early morning stiffness. Usually lasts for about, first hour of the day, 30 minutes to 45 minutes, whatever. Beginning of the day, they often say they feel like they can't even get out of bed. So the diagnosis is usually made looking at, does the patient or client have swelling of 3 or more joints? Do they have involvement of the knuckle joints, the metacarpal phalangeal joints, and the early morning stiffness? Those 3 things, swelling of 3 or more joints, involvement of the knuckle joints, and the early morning stiffness, is usually viewed as significant clinical manifestations. Okay, so in addition to the clinical examination, we can do some tests to try to diagnose rheumatoid arthritis. And sometimes initially, the primary care provider will start the tests, and then send the patient to a rheumatologist for more extensive testing. One blood test is the rheumatoid factor. And this rheumatoid factor is positive in about 70 to 80% of the patients. Normal rheumatoid factor is 0 to 20 units per ml. But a positive rheumatoid factor does not necessarily distinguish RA, because patients with lupus also can have a positive rheumatoid factor. So this positive rheumatoid factor has to be looked at with other tests. So another test that we order is the CCP2 assay. And this is usually positive in RA. And the sensitivity of this test is comparable to the rheumatoid factor. But it's really helpful to look at the CCP2 with the rheumatoid factor, because if they're both positive, then it really differentiates determining that they have rheumatoid arthritis. The CCP2 assay helps differentiate other problems that resemble RA. So some patients have a normal rheumatoid factor, but then they'll end up with a positive CCP2 assay, and that helps determine that they have rheumatoid arthritis. Also, we look at, is there inflammation? So looking at the SED rate, so the ESR, erythrocyte sedimentation rate, and this would usually be elevated in patients that have rheumatoid arthritis, signifying inflammation. And again, the normal SED rate is about 0 to 20 or 0 to 30 in women over 50. C-reactive protein also measures inflammation, and positive reading indicates active inflammation. And again, often these patients will have a positive C-reactive protein. ANA is also a blood test that measures antibodies that react with antigens. And normally in patients with rheumatoid arthritis, this will be positive. The higher the titer, the higher the inflammation. So in about 20 to 30% of patients, the ANA will be positive. So again, we're looking at the cluster of lab tests and trying to determine the SED rate, the ESR, the CRP, and the ANA can all be positive with lupus as well. So again, like I talked about, the CCP2 assay really helps try to differentiate if we're talking about rheumatoid arthritis, as well as the symptoms the patient's experiencing. Some patients might go through an arthrocentesis, not all patients. But again, we would be looking for the synovial fluid. And with rheumatoid arthritis, the synovial fluid could be cloudy, milky, dark yellow with lots of inflammatory components. And then the patient would usually get a series of x-rays. And this helps look at the progression, look at the joints. In the early stages of the disease, you might not see a whole lot, but initially soft tissue swelling might be visible. And then as the disease progresses, it shows the bony erosions and the narrow joint spaces. So x-rays are helpful to track the progression of the disease over time. A couple words about the arthrocentesis. Again, not all patients diagnosed with rheumatoid arthritis will get this, but sometimes it's helpful to do this to make sure that there's nothing else going on. So an arthrocentesis is done to find out why the joint is painful or swollen or fluid-filled. And they can also drain out fluid to decrease the pain and ability to move the joint. Arthrocentesis is helpful to diagnose the specific type of arthritis occurring within the joint and make sure that there's no infection or something else causing it. Also, it's helpful to look at if there's any crystals in the fluid or what's the components in the fluid to rule out other problems. Okay, so arthrocentesis is a procedure to take joint fluid out of the joint using a sterile needle. This can be done in most joints of the body, but it's usually done on larger ones, such as a knee or shoulder. And in some cases, the physician might inject medication into the joint, like a corticosteroid or something like that, after the fluid's been taken out. So it depends on the physician, but this could be done right actually in the office using some local anesthetic, or I guess it depends on the patient's preference whether they would need to have a little bit more sedation and be done in a surgery center. But typically this can be done in an office. Problems that can occur is with the procedure is infection of the joint, bleeding into the joint, and increased pain. So some factors that may increase the risk of complication. If a patient has infections on the skin or have had recent fever or infection or has a bleeding disorder or use of blood thinners, those will all be things that you want to be aware of before this procedure is done. So infections on the skin, recent fever or infection, bleeding disorder, or use of blood thinners. For the first 24 hours, an ice pack will be helpful, and the physician may order a pain reliever, or the patient might just take Tylenol. They might have just a Band-Aid on the site, or they could possibly have an ACE wrap on the site. And it's up to the physician what kind of activity they're allowed to do afterwards. Teaching, you want to talk to the patient about calling if they have any signs and symptoms of infection, fever, chills, purulent drainage, and if they have any redness, swelling, or increasing pain or bleeding at the site. And also any extreme pain that's not relieved by the Tylenol or the pain medication. Okay, so medications, we're going to talk in class about the medication, specific medications, but in general, medications are utilized with rheumatoid arthritis to reduce pain, but also prevent and delay joint damage and deformity, and to help improve daily function. Pain relief is the highest priority during the acute phase because pain is typically severe and interferes with the client's ability to function. So pain relief is the highest priority during the acute phase. Preserving joint function is the next goal, followed by preventing joint deformity during the acute phase to focus on optimal level of functioning and reduce the risk of contractures. So again, we want to also improve their quality of life. So you can read that list there. We're going to talk about medications in class, but I just want to use this time to talk a little bit about nursing considerations. So like I said, in the acute phase, relieving pain is a top priority. We work with our patients to prevent deformity. So early treatments with medications for the disease is optimal. Applying heat or cold to the affected area might be helpful. So recommending for your patient hot showers in the morning for stiffness, heated paraffin on their hands or fingers, or cold therapy for swelling. Teach the patients to participate in exercise. And again, similar to osteoarthritis, low to no impact aerobic exercise, walking, swimming, biking. Strength training might be helpful, but weight-bearing exercises are recommended as tolerated and are important to avoid immobilization. Patients are supposed to avoid positions of flexion during rest time, so preventing loss of functional ability and maintaining body alignment. Need to help them conserve energy. They might feel best early in the day. That might be the best time to get things done. Like I said, a warm shower might be helpful first thing in the morning for stiffness or before exercising. They might need to take frequent naps, sit while they're working, take regular breaks, if they're stirring cookie dough, that might be hard for them, or slicing up things or scrubbing the floor. All those things might be painful for them. They need to take regular breaks or have someone else help them. Again, same things with osteoarthritis, using a jar opener and a can opener and practicing good body mechanics. Patients need to know, when they're getting up out of a chair, to use their palms instead of like their fingers to get up out of a chair, and holding packages close to their body, all those good body mechanic things that reduce stress on their joints. Sliding objects when they can instead of lifting them. And then safety, promoting safety. Again, these patients might need to start using assistive devices. And working with physical therapy and occupational therapy, removing unnecessary clutter, providing information and support for them, support organizations for rheumatoid arthritis. We could come up with a lot of nursing diagnoses, but here's some of the ones I thought of. So impaired physical mobility. Again, we talked about acute and chronic pain. It's a high priority in the acute phase, the acute pain. Fatigue, disturbed body image, ineffective coping, fear, disturbed sleep patterns. A lot of these patients have difficulty sleeping or staying asleep because of the stiffness and pain. And we're going to, so we'll come back to more about rheumatoid arthritis medications in class. We're going to move on to lupus now. So lupus, again, we're dealing with the concept of immunity. Lupus is a chronic inflammatory autoimmune disease. It's more common in women and more common among African Americans and Caucasians. And similar to rheumatoid arthritis, lupus is characterized by remissions and exacerbations. Lupus involves the immune system, so it's the result of a disturbed immune regulation. The 5 phases are susceptibility. So we have predisposing factors, genes, gender, things in the environment, that then result in an abnormal immune response. And remember, we have the T cells and the B cells that are defender cells, and they're designed to recognize an antigen and multiply to find it. Okay? These B cells make proteins called antibodies. And in this case, we have these autoantibodies and immune complexes. So when you have lupus, your immune system cannot tell the difference between foreign invaders and your body's healthy tissues. So autoantibodies, auto means self and anti means against itself, are made to damage and destroy healthy tissue. So these autoantibodies cause inflammation, pain, and damage in various parts of the body. So we have inflammation and damage. You can also get drug-induced lupus, and usually the symptoms of lupus resolve when the meds are discontinued. So examples of meds that cause drug-induced lupus: Dilantin, some blood pressure medicines, and some TB meds. Again, risk factors for lupus include females between the ages of 20 to 40. Typically, the incidence of lupus declines after menopause. African American, Asian, or Native American descent. Okay, so what we're going to see clinical manifestations. It may be hard to make the diagnosis of lupus because the symptoms may develop slowly or acutely. It also may be confused with rheumatoid arthritis. But lupus changes cannot be seen on an X-ray. Lupus can be classified as discoid, which primarily affects the skin, and systemic, which affects the connective tissues of multiple organ systems and can lead to major organ failure. So the clinical manifestations, we see fatigue and severe joint muscle aches. And this is seen with about 95% of the patients. So the fatigue and the severe joint muscle aches. Skin problems occur with about 80% of the patients. Most characteristic is this acute cutaneous lesion, which you can see in the picture, a butterfly rash over the nose and cheeks. It can be red, itchy, or painful. Patients with lupus have extreme sensitivity to sunlight, might report weight loss, mouth sores, hair loss, low-grade fever, and depression. As the disease progresses, then patients can also exhibit central nervous system symptoms. So all of a sudden they're having like a mood disorder, depression, psychosis. They can have pericarditis, which is the inflammation of the pericardium, the sac surrounding the heart. They can have pleuritis, which is inflammation of the lining around the lungs. They're also at an early risk for heart disease, and they can develop renal problems, such as glomerulonephritis. It's estimated that about 50% of the patients with lupus have renal problems. Lupus can be life-threatening. We make the diagnosis for lupus. Well, lupus is sometimes called the great imitator because the symptoms are vague and resemble other diseases, such as RA, fibromyalgia, Lyme disease, etc. So you as a nurse can participate in obtaining a complete history and assess for symptoms such as the rash, the photosensitivity, the mouth ulcers, fatigue, etc. What makes it tricky is no single lab test confirms lupus. The ANA measures antibodies that react with antigens. So the ANA may be elevated in lupus, is usually elevated. C-reactive protein, again, is usually positive, which represents inflammation. The test that's helpful with lupus is the anti-dsDNA, and this is positive in about 75% to 90% of patients with lupus. So that can really help with the diagnosis. Like I said before, patients with lupus can also have high levels of rheumatoid factor. So it's really helpful to look at their symptoms all together and trying to get this anti-dsDNA test ordered so we can see, but again, that's generally positive in patients that have lupus. Lupus can be life-threatening, so it's important to determine if other organs are being affected, such as the cardiac system, pulmonary system, or kidney problems, and address it. And then the same nursing diagnosis that we talked about with rheumatoid arthritis can really be applicable for lupus as well. Okay, we are going to pick up in class talking about, we'll talk about the medication therapy for rheumatoid arthritis and also lupus.